Welcome to this lecture on neonatal hypoglycemia, an updated clinical blueprint for screening, diagnosis, and management. Practice in this area has evolved substantially, moving away from the fixed, time-based thresholds of the AAP's 2011 statement toward the evidence-based, operational framework published by BAPM in 2024. Over the next few minutes we'll walk through what changed, why it changed, and exactly how to apply it at the bedside. Let's start with physiology. Every healthy newborn experiences a drop in blood glucose in the first 1 to 2 hours after birth. This is the transitional nadir, and it is a normal, expected adaptation to extrauterine life, not a disease state. Glucose typically reaches its lowest point around 1 to 2 hours of age, then rises spontaneously as counterregulatory hormones activate glycogenolysis and gluconeogenesis, stabilizing by around 48 to 72 hours, day 4 in many infants. The critical zone, below 1.0 millimoles per liter, or about 18 milligrams per deciliter, is where the risk of acute neurological dysfunction and cerebral injury rises sharply. We are not trying to prevent the nadir, we are trying to make sure it doesn't fall into the critical zone, or if it does, that we respond immediately. So how has our approach to defining a problem evolved? The 2011 AAP guidance used time-based thresholds, anywhere from under 25 to under 35 milligrams per deciliter depending on age, with 4-dextrose or feeding as first-line treatment, and routine screening for any large 4 gestational age infant. The 2015 Pediatric Endocrine Society approach set a much higher target, above 50, but was really designed for infants with persistent, suspected pathologic disease, reserving 4-dextrose and specialist referral for that population. BAPM 2024 threads the needle differently. It applies to term infants at 37 weeks or later within the first 72 hours, simplifies the action thresholds to 2 numbers. Under 1.0 millimoles per liter is urgent, 2.0 is the operational treatment baseline, makes oral dextrose gel the first-line treatment, and no longer requires routine screening for LGA infants on that criterion alone. That last point deserves its own slide, because it changes who gets a heel prick in the first place. BAPM 2024 narrows routine risk-based screening to 3 groups: infants with fetal growth restriction, defined as birth weight below the 2nd centile, or a significant gap between occipitofrontal circumference and weight centiles, infants of any mother with diabetes, since good glycemic control reduces but does not eliminate the risk, and infants exposed to maternal beta blockers in the 3rd trimester or at delivery, which interrupt glycogenolysis. Large 4 gestational age alone is no longer an indication for routine screening, unless it's accompanied by maternal diabetes or syndromic features. This is a meaningful practice change, and worth flagging explicitly to your nursing and midwifery colleagues, since LGA screening has been reflexive practice for a long time. Now, how do we recognize when a baby is actually being harmed by low glucose, versus just showing normal transitional signs? Symptoms split into 2 categories: neurogenic, or autonomic, signs, tachypnea, sweating, tachycardia, a weak cry, reflect the body's counterregulatory stress response. Neuroglycopenic signs are the ones that matter most, because they reflect the brain itself running short of fuel: lethargy, hypotonia, apnea, central cyanosis, seizures, altered consciousness. 2 clinical pearls. First, deteriorating feeding behavior after a period of feeding well is a critical, easily missed early sign. Don't dismiss it. Second, jitteriness alone, in an otherwise well newborn, is common and does not by itself warrant a glucose check. Overscreening well infants for isolated jitteriness drives unnecessary intervention and NICU separation. Before we even talk about screening and treatment thresholds, prevention starts in the first 60 minutes of life, and most of it requires no intervention beyond good basic care. At minute 0, dry the infant, put a hat on, and maintain a warm, draft-free room to prevent cold stress, which itself drives glucose consumption. Between 5 and 30 minutes, uninterrupted skin-to-skin contact. By 60 minutes, initiate the first feed, with breast milk preferred, since it also boosts alternative cerebral fuels like ketone bodies. For formula-fed infants, target 40 to 60 ml per kilogram per day in the first 24 hours, increasing to 100 to 120 ml per kilogram per day by 48 to 72 hours. Once an at-risk infant is identified, screening follows a simple feed and screen loop. First feed within 60 minutes of birth. Then the first glucose check, taken before the 2nd or 3rd feed and no later than 8 hours after birth, using a ward-based blood gas analyzer rather than a bedside glucometer alone. Evaluate the result, 2.0 millimoles per liter or above. The infant returns to routine care and continues the feed cycle. Below 2.0, the infant enters the treatment flowchart. Monitoring can be discontinued once you have 2 consecutive pre-feed readings at or above 2.0 millimoles per liter with effective feeding established. This is the master reference table, worth committing to memory, or at least to your unit's laminated protocol card. 4 tiers. Urgent, glucose under 1.0 millimoles per liter, or any abnormal clinical signs at any glucose level. This requires immediate 4 glucose, no exceptions. Treat, a single value under 2.5 millimoles per liter. Treat with feeding or gel immediately. Do not wait for a confirmatory second reading. Escalate, persistent levels under 2.0 millimoles per liter on more than 2 occasions. Move to the escalation flowcharts. Specialist, glucose requirements above 3.0 millimoles per liter before 48 hours of age, or above 3.5 after 48 hours, which should trigger suspicion of hyperinsulinism and specialist liaison. These thresholds are grounded in the HypoExa trial, which showed a treatment target of 2.0 millimoles per liter was non-inferior to 2.6 for neurodevelopmental outcomes at 18 months in asymptomatic infants, the evidence base that allowed thresholds to come down safely. The single biggest practical shift in this guidance is the role of oral dextrose gel as first-line treatment. The evidence is compelling, a 42% relative risk reduction in treatment failure compared with placebo, and a number needed to treat of just 8 to prevent 1 NICU admission, 14% admission with gel versus 25% with placebo. Beyond the numbers, gel keeps mother and baby together, avoiding unnecessary NICU separation, which matters enormously for breastfeeding establishment and parental bonding. Dosing is 40% oral gel, 200 mg per kilogram, roughly 0.5 ml per kilogram, massaged into the buccal mucosa. One important caveat: this is a treatment, not a prophylaxis. The HPOD trial specifically found no benefit to giving gel before hypoglycemia actually develops. What does this look like in practice for mild, asymptomatic hypoglycemia, glucose between 1.0 and 1.9 millimoles per liter? First, confirm the infant is completely asymptomatic, with no red flag signs. Then breastfeed or formula feed and administer 40% oral glucose gel at 200 mg per kilogram buccally. Recheck glucose before the next feed. This cycle can repeat, up to 2 doses 30 minutes apart per episode, with a maximum of 6 doses in 48 hours. If the infant remains persistently below 2.0 millimoles per liter after 2 full gel cycles, escalate to the 4 pathway. For severe hypoglycemia, glucose under 1.0, or any abnormal clinical signs at any level, this is an emergency. Obtain 4 access immediately. Priority labs can be collected simultaneously but must never delay treatment. Give a bolus of 2.5 ml per kilogram of 10% dextrose, followed by an infusion of 10% dextrose at 60 ml per kilogram per day. If 4 access is delayed, bridge with buccal gel at 200 mg per kilogram, or intramuscular glucagon at 200 micrograms per kilogram, maximum 1 mg. Then enter a tight titration loop with glucose rechecks every 30 minutes. If still under 1.0 or symptomatic, repeat the bolus and increase the infusion by 2 mg per kilogram per minute. Between 1.0 and 2.5 with no symptoms, increase the infusion by 2 mg per kilogram per minute and continue feeds. Above 2.5, begin a slow wean of the 4 while continuing feeds. When should you start worrying about an underlying metabolic or endocrine disorder rather than simple transitional hypoglycemia? 4 flags. A glucose infusion rate exceeding 8 mg per kilogram per minute to maintain normoglycemia, persistence beyond 48 hours, syndromic features, or a relevant family history. Note that the target glucose range explicitly rises in this context, above 3.0 millimoles per liter before 48 hours, and above 3.5 after 48 hours. If a pathologic cause is suspected, the critical sample is everything. Draw it during a spontaneous low, before any treatment alters the metabolic picture. That sample should include glucose, free fatty acids, insulin, and C-peptide, and beta-hydroxybutyrate, often the only chance to make a biochemical diagnosis before treatment normalizes the numbers. Before discharge, 4 boxes need to be ticked. Time: a minimum 24-hour observation period completed for all at-risk infants. Values: 2 consecutive pre-feed glucose readings at or above 2.0 millimoles per liter. Function: mother and staff satisfied that feeding is effective and sustained across multiple feed-fast cycles. Clinical: 0 signs of neuroglycopenia, with any underlying risk factor, like cold stress, fully addressed. All 4 together, not the glucose number in isolation, determine readiness for discharge. Let's close with the 5 changes that matter most for your daily practice. 1. New thresholds. Under 1.0 millimoles per litre demands urgent IV therapy, and 2.0 is now the operational baseline. 2. Narrower screening. LGA alone is no longer an indication for routine screening. 3. Symptom nuance. Isolated jitteriness is not a trigger for glucose checks, but deteriorating feeding behavior is. 4. Gel is first line. 40% dextrose gel at 200 mg per kilogram prevents unnecessary NICU separation for mild, asymptomatic cases. 5. The hyperinsulinism trigger. A glucose infusion rate above 8 mg per kilogram per minute should prompt an immediate workup and higher target glucose levels above 3.0. That's the BAPM 2024 framework in full. Thank you.